Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, Tips, and Practical Tips. What I'm going to be sharing with you today is a nice example of a mixed germ cell tumor of the pineal gland. So this is a 6-year-old male patient who presented with the precocious puberty. So during investigation, MRI of the brain was ordered, and it was luckily ordered because a pineal gland tumor or mass was identified, for which he underwent craniotomy. And as you can see here from the low power magnification, what I really interpreted initially this area as probably this is the normal pineal gland with the calcification normally encountered in the pineal gland. I have to say it's a bit more cellular than what you would usually encounter in the pineal gland. However, it wasn't much of an eye-catching pathology that I could identify. And at high power magnification, these are the calcifications or the samoma bodies, which are normal constituents of the pineal gland, and perhaps some large cells scattered here and there, not really much convincing pathology. And this is the area that really gave the most important clue, because we started to see cells with large, abundant, clear cytoplasm, vesicular nucleus, and a prominent nucleolus, and perhaps some scattered inflammatory infiltrate here and there. And the synaptophysin, of course, was positive in the background pineal gland tissue that really constituted most of the tissue in the biopsy. And there were those scattered cells or groups of cells that were completely negative, that stained with SAL4 as well as OCT3/4, consistent with germinoma, and CD30 was completely negative. So this ruled out the possibility of embryonal carcinoma. However, the finding of a germinomatous component would not really, in most part, explain why the patient had a precocious puberty. However, other fragments were composed of only blood clot-like tissue, lots of hemorrhage and necrosis, but this was punctated by some of those cells, which on higher power magnification were really large cells with hyperchromatic nuclei, sometimes multiple nucleoli, in a way that you should make you suspicious of syncytiotrophoblasts or a choriocarcinoma component. And this is another focus where we have large areas of necrosis, and then those scattered large cells dispersed in the hemorrhagic/necrotic areas that we usually really don't pay much attention to, especially whenever we have a viable tissue. And those areas were strongly positive with GATA3. So all those punctate cells dispersed among the hemorrhagic and the blood clot fragments were GATA3 positive, and this is on higher power magnification. And remember, GATA3 is extremely useful in showing the syncytiotrophoblasts, in particular in cases of choriocarcinoma, but even as a component of germinoma or other germ cell tumors. And this is the beta HCG. The issue with the beta HCG is that because it diffuses into the serum, sometimes it is difficult to read. And as you can see here, you would say probably most of the tumor cells are negative. Some of these tumor cells are positive, but I honestly find GATA3 much more robust immunohistochemical stain to support in the appropriate context, in support with other clinical as well as immunohistochemical markers of choriocarcinoma component. Remember that quite often then not SAL4 is negative in the choriocarcinoma, whether the cyto or the syncytiotrophoblasts. So the final diagnosis of this amazing case is mixed germ cell tumor of the pineal gland, composed of germinoma and choriocarcinoma. Remember that whenever a child presents with this unusual presentation of precocious puberty, one area that you should really look for possibility of a tumor is the central nervous system, including the pituitary as well as the pineal gland region. Remember that because of the germinoma component usually is intermixed with the normal constituents or normal structures of the pineal gland, it might not be easy to identify unless you have really some suspicion and then you apply the appropriate immunohistochemistry. Remember that choriocarcinomas tend really to hide in between areas of hemorrhage and necrosis. So whenever you see these, in particular in the context of a germ cell tumor, you have to actively search for the presence of a choriocarcinoma component, whether syncytiotrophoblasts or a mixture of both. Remember that sometimes those might be really the cells responsible for the abnormal production of the beta HCG that will lead to explain the abnormal presentation of precocious puberty in children. I hope you find this tip useful in your daily practice. Thank you.